Let's talk about Ozempic, which is the drug everybody's talking about these days, being the GLP-1 agonist, and then this natural sweetener, allulose, and the similarities there.
Sure. So, Ozempic is a fascinating drug. As we eat food, unfortunately, we don't have very good mechanisms for us to say we should stop eating. And our biology is designed like that because our biology was designed in an era of scarcity. We didn't have enough food around, and having mechanisms for overeating created a survival advantage. So, a person eating food, what happens is the food gets digested in the starts the digestion process in the stomach, then further digestion happens in the duodenum, and then it reaches the later part of the small intestines, which is called the jejunum. So at the level of jejunum, which would be several hours after you have eaten, like 90 minutes, 2 hours after you have eaten, the body is then giving signals because there are K cells and L cells in the jejunum that make a compound called GLP-1. So GLP-1 is a very specific compound that does the following things. It makes your stomach stop emptying. So in other words, your stomach feels full because your contents stay there. It happens to me, it happens to a lot of my patients. I'm eating, my stomach is hurting, and yet I have this desire to overeat. I mean, I have this desire to continue eating. And I used to wonder, why is this happening? And the reason it's happening is that my biology is designed for me to overeat. I mean, I was asked to overeat because it was a survival advantage. And then I reach about an hour and a half later, and my stomach feels even worse. And I'm saying, why is that? I mean, I wanted to eat more. I stopped because my stomach hurt. But now it's an hour and a half later. The food should have moved, and my stomach should feel less worse. But it's feeling worse because now the GLP-1 has kicked in. It's telling my stomach to stop emptying. It makes me feel even fuller. And so the mechanisms to stop eating are delayed, and they are later and later, perhaps, than it should be for our environment that we live in with overabundant food, engineered food, highly palatable food, whatever you want to call it. I can make food that is a super normal stimuli for me to overeat. Even me. I mean, I don't even have to go to food engineers and food industry to blame them for that. The second thing that GLP-1 does is that it goes and talks to, and I think these are the pleasure centers of the brain, and it improves satiety. It improves, it reduces hunger. So you're not hungry, it reduces your hunger, it slows down your gastric emptying, and then it has a few other effects. It improves pancreatic beta cell function, it regenerates the pancreas that's making insulin. So it's a great thing, but the GLP-1, the half-life of that is relatively short, few minutes or something like that. So the drug company is very good at extending the half-life of this agent. So they take the GLP, they add a fatty acid chain, then they add another residue that prevents it from being removed by the enzymes that remove it in our body. So initially it would last for like 24 hours, but with further fatty acid modifications, further modifications in the residue at which the peptidases that degrade this GLP-1, they become resistant to that. So it's now lasting for a week. So when you take a GLP-1 agonist, you're not hungry, your stomach feels full, you eat less. And so I said, this is fantastic. This is something that is evening the playing field. Our biology is designed for 50,000 years ago. Now we are living in a different era. We have this constant barrage of stimuli that are coating our dopamine neurons, wanting us to overeat. Can GLP-1 level the playing field? And I think it does. And I think these are useful drugs when used properly with the right degree of instruction to the patients for them to start improving their metabolic health. Because when you take a GLP-1 agonist, studies have clearly shown that these things happen. Number one, your blood pressure drops. Many people are hypertensive. Number two, your triglycerides, which is fat in blood, reduces. Number three, your HDL, which is a clearing mechanism for atherosclerosis, which is called good cholesterol, goes up. Number four, your insulin levels drop. So you become more fat burning, you store less fat. Number five, over 1 year time, you can lose about 10 to 15% of your body weight. So why not use that in patients who are appropriate for it? So I do prescribe this drug. I tell them that watch my YouTube video, look at some of the side effects of these drugs as to, the three side effects that you're paying attention to is nausea, vomiting, and constipation, because it's slowing down your gut. You don't want to take it to the point that you're nauseated, you're constipated, and you're throwing up. You want to keep the level of the drug much lower. The second and the most major problem with this drug is an off ramp. How do you get off of it? Because once you get off of it, are your feeding mechanisms going to come back? In other words, are you going to start, eating more and regain the weight? And you are, going to not have any slowing of your gastric emptying. So studies have shown that when people stop this drug, they regain 60% of the weight that they have lost in the first year, which is very devastating. But new data is beginning to emerge, not solid, it's anecdotal, it's empirical, that if people have honed in on fasting, exercise, and a low carb diet, the off ramp becomes a lot easier without the regain in weight that you would expect. The fourth issue that I have explored in my practice, and anybody who comes on this drug to my practice is asked this question: do you lose the pleasure in eating? Because eating is a pleasurable activity. And if you are going to take away your dopamine neurons or the activity of your dopamine neurons, you can perhaps lose the pleasure in eating. But many people come back and tell me that their quality of life improves. And the reason their quality of life improves is that having better self control over their food choices and not being or being able to resist temptation and have better willpower gives them a sense of well being. It makes them feel better about themselves. So I've hardly come across any person who tells me that they lose the pleasure in eating. They say the pleasure in eating is there, but the excess munchies, the overconsumption is gone. So I am not against these drugs. I think that these drugs should be used, but they should be used with a proper instruction on what they do, how they work, and how to use them to your advantage.
Okay, my pushback is why not just use the diet, exercise? What was the third? Oh, fasting component. Is this for a select population? How do we determine who it's right for? Is it a band-aid for somebody that could be applying the lifestyle and diet stuff? How do you look at that?
That's a very good pushback. So the way I counteract that is three ways. Number one is that you have given this advice to people on three separate visits about 3 months apart, and they have tried their best and they have failed. And you tell them, hey, go do the same thing over and over again. So, in other words, try the same that you have failed 3 times, try it a fourth time or a fifth time. So, they need to have an additional tool in their toolbox through which they can improve and modulate their health. Number two is that we have to recognize that we are all very different. My dopamine neurons may be not as good as yours. In other words, I might be more susceptible to temptation. Dopamine neurons, when they are coated by food industry, by the food that I prepare, or by anything else in my environment, may be firing in such a way that I am destined to a life of overconsumption and addiction. And I may not be able to deal with that without some additional help. So in other words, I'm just evening the playing field between the environment and the person. And then when I see all the dramatic health benefits, in other words, increase in HDL, drop in your triglycerides, drop in your blood sugar, drop in your blood pressure, drop in insulin levels, drop in weight, it becomes a little hard to argue that you should not use it in people who have failed the traditional diet, exercise, and fasting guidelines.
Okay, my other pushback, when you start messing around with dopamine, what if that affects other areas, like your drive for work or other areas of life?
Yeah, dopamine is a very strong drive hormone. It's a wanting, it's a movement, it's an action hormone. It's not a pleasure chemical. It's something that makes us do things. It provides us with motivation and energy. And if it's doing that, then yes. But when I talk to my patients, their improvement in quality of life is dramatic. Like, for example, I go home after 12 hours of work, and you would expect that I would say, okay, I should rest, I should sleep. But I'm media addicted. So I go to YouTube and I'm scrolling the YouTube channels, trying to find something that would provide me a dopamine hit. So that's addiction, not pleasure. And our environment, our current day environment, is full of signals that are coating our dopamine neurons. And how do we even that playing field? Can we even it just by recognizing what's happening to us? And yes, maybe some of us can do that. Do some people need a touch of help? I cannot tell you how many healthy young men come to my office and say they take a little bit of Manjaro, which is an Ozempic like drug, just to take that edge off and make them behave better in terms of discipline and focus. So I'm giving you a pushback in the other direction.
So they're
I
not
think
just laying around on the couch playing video games all day.
correct. So dopamine neurons can get you to drive and do excellence, but dopamine neurons can also get you addicted to bad things in which you're just sitting down and playing video games and taking in tubs of ice cream.
All right, I want to respect your time. I know we're already pushing it here, but I'll end on this because I already brought it up. Allulose. So this is another pushback. If we know this has a similar effect, why not use something like that versus a drug? So talk about the differences there.
Very good question. So let's talk about allulose a little bit. So the simple way to describe allulose is that it is fructose. Now, fructose is a 6 carbon molecule, and I think, I'm not sure, at carbon 3, you have oxygen at one side and a hydroxyl group at another side. So you take an epimerase and you flip it. So what it does is that it is absorbed. It's about 50% as sweet as table sugar, I mean, regular sucrose, and maybe 50 to 75%. It is absorbed, but it doesn't enter any oxidation. It doesn't enter the glycolytic pathway. So, in other words, it's not burnt. It doesn't get converted to fat, so you don't store it. And you eliminate it unchanged in urine. So, it's providing you with a sweetness. It is not burnt or stored, which is fantastic. And unlike the other sweeteners, it does not have an aftertaste. It is as close to real sugar as possible. Now, there are some animal studies that show that when you take an allulose, that you stimulate the L cells and you increase GLP-1 levels. In other words, it's like you are taking an Ozempic-like drug every time you eat. Unfortunately, there are only rat studies that show that. There is not any animal study that shows that. So I have been giving allulose to a number of my patients. I ask them, how well does it work? So they say, as a sweetener, it works fantastic. As an agent that is curbing their appetite and making them eat less, the jury is still out. I want to see human studies that are showing that allulose is actually increasing GLP-1 levels rather than having to rely on rat studies alone. If my clinical experience with the drug, in other words, giving it to patients and them coming back and telling me that, hey, it works fantastic, is just not corroborated yet. And in fact, I think it's leaning in the other direction, in which people say, no, it doesn't really curb my appetite. So I don't want to push the compound that much. I think it's a good sweetener. It's probably the least harmful of all the sweeteners.
All right. Well, the jury's still out, but we'll have to follow up and see what you're seeing with patients longer term. If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
Phytosterol levels are significantly increased in people who are taking a statin. And this phytosterol is causing damage and harm that has not been properly investigated. With regards to the canola oil,